That explanation I gave you that.
Yes, yes, it is. So you're, I literally don't, I don't know if you saw, but I tried every other option.
I was talking to a nurse anesthetist, January, and he said, I will explore any other option before I use etomidate. I hate etomidate because of the adrenal suppression. The adrenal suppression can be pretty severe. And I asked him, do you give hydrocodone? He said, I do, but sometimes it doesn't work. Yeah.
And you're one of them. I would want it. Thank you. No, I know. That's not what I was gonna say. I don't have any.
Well, good evening, everyone. It's glad to be back in class. If surveys of students, if informal surveys of students are to be believed, students despise learning by Zoom. So I don't think teaching by Zoom is ideal. I won't throw a tantrum if I have to do it, but I will say it's not my favorite thing in the world to do, but hey. There are worse things I've had to do, so, you know, way it goes. All right, I've got some other stuff to get back. I'll get that back during the break. Okay, oh. Yeah. All right, we are talking about NSAIDs. And we are interested in how they work with respect to their ability to kill pain. So we left off more or less where we saw that the cyclooxygenase enzymes, they come in two different isozymes. Now, is there anyone who doesn't know the word isozyme means? The whole class, all right. Okay, here's Reader's Digest definition of an isozyme. So let's say you're playing poker. And let's say Olivia has an ace. It's the ace of hearts. Let's say Jocelyn has the ace of spades. Now, which card is higher? The ace of hearts or the ace of spades? In poker, this is not like euchre. In poker, neither one. Neither one, but they're different suits of aces. They're different isozymes of aces. They both have the same value, but they're different types. Same thing with isozymes. The enzymes catalyze the same reactions. They might have different kinetics. So the rates at which they catalyze the reaction might be different. They might be regulated differently. They might have slightly different substrate specificity, and they might be located in different parts of the cell. But they are encoded typically by different genes, or they might be splice variants of the same gene, which is learning about in genetics now. But they are two different proteins. So they have similar ways of catalyzing the reaction, but there are idiosyncrasies about the enzymes that are different. So cyclooxygenase 2 is induced. It's induced by inflammation for the most part. Cyclooxygenase 1 is a housekeeping enzyme. It is on at low levels all the time in certain tissues. So it's this term we use for such things, constitutive, not the easiest way to say it, constitutive. Constitutive, let's write that down. So COX-1 is constitutive. So at low levels, all the time, housekeeping enzyme. 3 places where COX-1 is very important from a functional perspective. GI mucosa, particularly the stomach, very important. COX-1 makes prostaglandin E2. Prostaglandin E2 does several things. It increases mucus production. Is mucus important in the stomach? Yes. Why? Stomach makes a lot of acid, makes a lot of hydrochloric acid. Mucus protects the gastric glands from acid damage. Also protects it from enzymatic damage. 2, it increases the production of bicarbonate. That mucus is laced with bicarbonate. That neutralizes the acid. So when the acid gets near to the mucosal surface, it's not only encountering a barrier, it's encountering a barrier that neutralizes the acid. 3, it increases mucosal blood flow. And 4, it's not on there, prostaglandin E also increases the mitotic index of the mucosal cells so that the stomach regenerates better. Consequently, if you inhibit COX-1 in the stomach, you decrease mucus production, you decrease bicarbonate production, you decrease blood flow into the stomach, and you decrease the healing capacity of the stomach. Can you see what a disaster this is in the stomach? Okay, Devin, you're nodding your head. Tell me what happens in your own words.
I just know that if the mucus is not there, then the acid is gonna degrade all of your tissue.
Right,
So.
You're gonna get- you're gonna get PUD, peptic ulcer disease. Rhymes with bud. PUD, peptic ulcer disease, and that is due to the NSAID inhibiting the activity of COX-1 in the stomach. So that's the first place where NSAIDs will have their first set of side effects. If you take them long term, they can cause peptic ulcer disease. Second place where NSAIDs can make their side effect profile known is in the kidney. So in the kidney, you actually make low levels of COX-1 and COX-2. So in this case, COX-2 is not inducible. It's also constitutive. So COX-1 and COX-2 help synthesize prostaglandin E and prostaglandin I. What do those do in the kidney? They cause vasodilation of the afferent arteriolar component of the glomerulus. They increase blood flow through the kidney. And it also increases excretion of sodium in water. If you decrease perfusion through the kidney and decrease water and sodium excretion, what do you think happens to your homeostasis with respect to electrolytes and water concentration, so on and so forth? You retain water, you retain sodium, you decrease blood flow through the kidney. That's going to induce the renin-angiotensin-aldosterone system. Increase blood volume, increase blood sodium. You're activating the renin-angiotensin 2 aldosterone system. This is going to raise blood pressure. It's going to raise blood pressure substantially. And if you chronically decrease blood flow through the kidney, you can cause kidney damage after a while. Now, please understand it. If Catherine here says, pharmacology gives me a headache, and she goes home and she pops some ibuprofen, is she going to wreck her kidneys? No, no. This is chronic. This is a chronic effect. Now, if Catherine had proceeded to take ibuprofen every day because she just can't live with farm in her semester without ibuprofen and lots of it every day, yeah, now she's going to wreck her kidneys. Don't do that. But if she says, I've got a headache, that weird guy with the funny last name, because he gave me a headache tonight. She goes home, she takes Motrin. Oh, Jocelyn, stop. Nothing sitting there, yep, Catherine, that's not going to erode her stomach or affect her kidneys. This is long term. Long term. Third place, where NSAIDs can make their side effects, long-term side effects, apparent. And that is in the cardiovascular system. Now here you have an interplay between the endothelial cells and the platelets. Do platelets have nuclei? No. So they can't remake enzymes if you inhibit them permanently. Endothelial cells, they have nuclei. They can remake enzymes if they're inhibited permanently. So the endothelial cells, it turns out, have a constitutive COX-2. Low levels of COX-2. And they use that to make prostaglandin I, otherwise known as prostacyclin. That causes vasodilation. That tends to diminish platelet aggregation. The platelets have COX-1. And when activated, they use COX-1 to make thromboxane A2. Thromboxane A2 causes vasoconstriction and platelet aggregation. Now, here's what happens when you take aspirin. So if you take aspirin, so here are your endothelial cells that line the blood vessel. And here are your platelets. They're not activated yet, so they're still round. When platelets get activated, they get all these processes and they look star-shaped and they just go really bonkers. So these cells here, are making prostacyclin. Now, aspirin is unique among the NSAIDs because aspirin is an irreversible inhibitor of cyclooxygenase enzymes. So these cells have COX-2. These cells have COX-1. If you take an aspirin, you get rid of both of them, but these cells can remake their COX-2 and they will continue to make prostacyclin. Can these cells remake their COX-1? No. So this is the reason why people at risk for stroke or heart attack are told to take a baby aspirin. If they take a baby aspirin per day, they essentially take the teeter-totter where we have platelet activation, and over here we have baby aspirin takes the teeter-totter and tips it this way. That's why baby aspirin is recommended for people who are at higher risk of stroke or heart attacks. Because you'll tend to not have those strokes or heart attacks, because remember, strokes and heart attacks are brought on by the production of thrombi. This tips the teeter-totter more towards the, no, you're not going to clot right now. Now, what if we use these drugs that are COX-2 specific inhibitors? Now what happens? They do not inhibit this one, but they do inhibit this one. Now what do we do to that teeter-totter? Now the teeter-totter goes this way. That's why the COX-2 specific inhibitors have been linked to higher risk of stroke and heart attack. That's why most of them have been pulled from the market, with the exception of celecoxib, otherwise known as Celebrex. You understand? Now you might be thinking, what about drugs like ibuprofen or naproxen, something like that, over-the-counter NSAIDs? These do not irreversibly inhibit the COX enzymes. So they will inhibit both of these, but because they're irreversible inhibitors, they essentially make the playing ground neutral. And then as they are removed from the body, you're back with this balance. So they don't seem to increase heart attack and stroke nearly as much as the COX-2 specific inhibitors. Seeing a few blank stares out there. Which usually means you don't understand. So, which part don't you get? Yeah, Paige?
I mean, I'm trying to do some mild it, but, feel like the ibuprofen, so like that doesn't work the same way as the
No.
aspirin, it's just-
That is a competitive inhibitor of COX-1 and COX-2. Aspirin actually binds covalently to the enzyme and kills it. It's a suicide stop substrate. So the enzyme is kaput, dead. This is the reason why, if you have surgery, you're told don't take aspirin at least 9 days before your surgery. Because how long do platelets last? 5 to 9 days. Once you take aspirin, you killed all your platelets. You have to wait now for the platelets to be replaced. It takes 9 days for all your platelets to be replaced. And you want to be able to clot your blood after surgery, or you're going to be one dead maru because you don't can clot your blood. That's the reason they give you that instruction. These others, they bind, they let go. They bind, inhibit, they let go. Bind, let go, bind, let go. That means they're going to inhibit the enzyme in a concentration dependent fashion. And the platelet doesn't have to remake the enzyme or anything, because it's not permanently inactivated. With aspirin, aspirin's unusual. Because aspirin binds to the enzyme, forms an adduct with it, and it's kaput. It's dead. Elena, you were the one giving me the worst stink eye.
I
In
guess I
terms
don't
of-
really understand like the teeter-totter, like a platelet reactivation.
So you have a balance in the bloodstream of platelet activation and platelet inhibition because the cells of the endothelium are making prostacyclins. And the platelets, they're ready to make thromboxane A2, but you have this balance between them. If you take the baby aspirin now, the environment inside the vessels becomes very anti-platelet activation. So if your vessels are beat up a little bit, you've got the atherosclerosis, you've had some high blood pressure, you've got some diabetes or something like that. The baby aspirin will tend to take the little teeter-totter, which one is heavier essentially. You know, when you sit on a teeter-totter, you know, like that, and then your big brother comes and sits on the limb, your friend goes off and, off in the middle or something like that. This essentially is aspirin sitting on that side of the teeter-totter, and now the platelet activation side it's harder to activate the platelets. So it's harder to make clots, to make an embolus inside your vessels. That's why doctors will recommend baby aspirin a day for someone who has atrial fibrillation, who's had a stroke, who's had an MI, who's had, whatever. Because you're increasing, essentially, you're taking the prostacyclin, you're inhibiting COX-2, but the cells can remake it, whereas the platelets can't because they don't have nuclei. And there was a big study that looked at the cardiac effects of over-the-counter NSAIDs, not including aspirin. And naproxen sodium seems to be the safest when it comes to the heart out of those. But in general, they don't increase the risk of heart attack that much. Some of the prescription NSAIDs inhibit COX-2 more than COX-1, and they definitely present more of a cardiac risk. So meloxicam, for example, meloxicam is used a lot in people with osteoarthritis. But it's used long term and it shouldn't be if someone's got a bad ticker, because you're increasing that risk, you're increasing the thrombotic environment inside the vessels. when you do that. So. Okay, who else was giving me the stink eye back there? McKenna, oh, I never know what you're thinking, McKenna, so. Do you have any questions, McKenna? You don't? The teeter-totter? The teeter-totter simply means that you're waiting platelet, okay, focus. You're waiting platelet inhibition more than platelet activation by taking the aspirin. Your big brother comes and sits here, and now this is the heavy end, so this is the end that predominates. Except the big brother in this case is aspirin. So if someone is on NSAIDs, that means the three places where you are going to have your biggest concerns will be essentially, you're going to ask them about their GI tract. You might even want to just palpate the stomach. And if there's a tender spot, ooh, ow. Might want to get that scoped. We might want to do something about that. If they're going to take the NSAIDs long-term, they should also probably take a proton pump inhibitor because that will prevent ulcer formation. The other thing is you might want to ask about, are you drinking? What's your urine output? So on and so forth. And any chest pain, any shortness of breath, any, stuff like that. So let me back up here. So NSAIDs are used for pain. So that means they're used for the pain associated usually with arthritis, typically osteoarthritis, but it can be rheumatoid arthritis as well. Mostly skeletal muscular pain, also for anti-inflammation. So gout. That's one place where they get used a good deal is gout. Antipyretic. They're antipyretic agents. Kara, can you tell me what antipyretic means? Person, can you help her out? Paige? Fever. Decreases fever. Antipyretic means it brings down a fever. Now, the literature is really starting to show that fevers actually help you fight infection. But if you have inflammation that's giving you a fever, the fever is really preventing you from being able to do stuff. Being able to kill the fever might be a good idea. So to kill the fever, and aspirin in particular is a good prophylactic treatment to prevent myocardial infarction. That's the case with aspirin. So on your handout, you can see there's two groups of NSAIDs. There is aspirin, salicylate, and difluzinol. NSAIDs in general cross the blood-brain barrier. That's one of the main ways they prevent, or rather quell fever. Difluzinol does not cross the blood-brain barrier, therefore has no antipyretic effect. All its effects are peripheral. So aspirin comes in an 81 milligram tablet. That's the baby aspirin. They're chewable. They even come flavored. Remember, with aspirin, you do not give children under the age of, well, to be safe, 18, aspirin if they have fever from a viral infection because of the risk of Graves' syndrome. We talked about that in micro, I'll bring that up again. The exact mechanism of Graves' syndrome is not well understood, but aspirin plus a viral fever somehow combines to cause very severe liver damage. So these are the salicylates. The more classic NSAIDs are the ones on the bottom part of your handout. So of those, ibuprofen and naproxen sodium are over the counter. The others are by prescription. However, diclofenac, topical diclofenac comes as a Voltaren. That's a rub for sore muscles. That you can buy over the counter now. Oral diclofenac, though, is prescription. All right, so they are used for pain. Aspirin should never be given in a patient with gout because at typical doses of aspirin, they prevent the excretion of uric acid, and gout is due to high uric acid levels and the crystallization of uric acid in joints. So aspirin is not to be used, but the other NSAIDs can be used. So aspirin is contraindicated in cases of gout. So here are some of the classic NSAIDs. These two, of course, are over the counter. You can also get various types of, at least with ibuprofen, there are some combinations of opioids with ibuprofen. I'm not aware that there are any opioid combinations with naproxen that are available commercially. I can't think of any. Ketorolac is marketed by the trade name Toradol. Any athletes here, it's used usually for athletic injuries. Any athletes here ever had a Toradol shot because of a bad injury? Athletic trainers can actually give shots of Toradol if you have a really bad injury. Very good painkiller, has opiate type effects. However, it's addictive. It's addictive. So it's used for postoperative pain. It's used for post-injury pain. Diclofenac comes as an ointment. You can put on sore muscles. It's very good for that. The absorption through the skin is not terribly high. In fact, some of you may have been exposed to wintergreen oil. That's for sore muscles sometimes. Wintergreen oil actually has salicylate in it. But again, the absorption through the skin is pretty low. This is available as a product you might know as Bengay. That's wintergreen oil. And it's used sometimes in atomic bombs and things like that trainers use. Meloxicam is used a good deal in people with arthritic pain. This is a stronger COX-2 inhibitor than it is a COX-1 inhibitor. So you have lower amounts of GI disruption with meloxicam, but you don't want to give this to people with bad hearts. For rheumatoid arthritis and osteoarthritis, there are these other forms. These are more powerful forms of NSAIDs. There are also 3 forms that come in these nanoparticle encapsulated slow release forms. The theory behind these is that if you get a little bit of NSAID over a period of time, your NSAID levels don't really go that high, so you're avoiding side effects. That's not been established, but the drug companies made it, so they're available. And unfortunately, they're a lot more expensive. Indomethacin, I think I should mention, is used in neonates who have patent ductus arteriosus. So the ductus arteriosus is a bypass between the aorta and the pulmonary vein. The reason you have that bypass is that the lungs are the last thing to mature in the fetus. So not much blood goes to the lungs, and the right side of the heart will tend to have higher pressure than the left side of the heart. When the baby takes her first breath, you have the production of, well, rather, the prostaglandins that are made that keep it open all of a sudden cease. Also, pressure now on the left side becomes much higher than pressure on the right side, and that closes. And when you dissected your beef hearts, there was that little artery that held the aorta and the pulmonary vein together. That's the ligamentum arteriosum, and that's a remnant of the ductus arteriosus. In some babies, that puppy stays open because the cells keep making prostaglandins. In this case, you give indomethacin. It shuts down the production of prostaglandin E and G that keeps it open, cinches down, and the little tyke now is all good. So that's one big thing indomethacin is used for. It's used to treat patent ductus arteriosus. And some of you I know are interested in neonatal medicine. That occurs often enough, you will see it in your practice. And indomethacin, which is very hard on the stomach, comes in this nanoparticle encapsulated release form. So of the COX-2 specific inhibitors, celecoxib is the only one that's left. All the others got pulled from the market. So Vioxx, rofecoxib, that got pulled. So did Vextra, valdecoxib, that got pulled too. Now there's just one left. It's used predominantly for arthritis. So these drugs work by reducing prostaglandin synthesis. By reducing prostaglandin synthesis, they will reduce inflammation, temperature, pain, and in the case of aspirin, they will reduce platelet aggregation. Catherine.
Is this all the NSAIDs or just the, like?
All the NSAIDs with the exception of platelet aggregation, that one is restricted to aspirin. So they get used for fever, mild pain, chronic pain, typically arthritis pain, rheumatoid arthritis or osteoarthritis. They decrease inflammation. In the case of low-dose aspirin, they can prevent heart attack or stroke. Except for COX-2 inhibitors, they actually make it worse. Aspirin has also been shown to be effective in the case of colon cancer. Colon cancers, it turns out, make very high levels of cyclooxygenase enzymes. And those cyclooxygenase enzymes actually aid their ability to invade the intestinal wall and spread. And it turns out that aspirin, when given with chemotherapy, actually augments chemotherapy because it inhibits those COX-2 enzymes made by the colorectal carcinoma. Aspirin is still one of the main causes of overdose, particularly of little kids. Because little kids get into the medicine cabinet and they seem to be better at opening the childproof caps than the adults are sometimes. And they get in and they, that tastes funny, let's try another one. And poison centers, one of the main poisons that they deal with is aspirin, believe it or not. So the signs of aspirin toxicity are important to recognize. So you get, one of the first side effects you get when taking NSAIDs long-term is peptic ulcer disease. So you get an ulcer and it might bleed. With aspirin, one of the first signs of aspirin toxicity is ringing in the ears, tinnitus. Aspirin then causes acidosis. So you actually get stimulation of the respiratory centers. You start to hyperventilate. You then start to get, paradoxically, a fever. You get dehydration, seizures, and it can end up in hemorrhage because platelets are inhibited, and death. If someone overdoses on aspirin, the old recommendation was that you give them something called Ipecac. Ipecac induces vomiting. They don't recommend that anymore because Ipecac is really hard on the stomach. What's recommended instead is to give activated charcoal. Now, you guys will learn more about giving activated charcoal. Activated charcoal is a mess because what goes down has to come up. And the patient, make sure you put bibs on them or something like that, because it's going to come up and it's going to be yucky, and make sure you're protected. You should probably have a face mask on and something like that. So when you give activated charcoal, look out below.
So what's like the time frame that you have to give them something?
Depends on the weight, height. If it's a kid, the time frame, of course, is much shorter. You need to get them to the emergency room. They need to get activated charcoal ASAP. Because aspirin, unfortunately, is absorbed relatively quickly in the stomach. But a good portion of it is absorbed in the small intestine. So if you give activated charcoal in a timely fashion, usually within the first hour, you can get most of it out. And then any acidosis, you can just give the little guy out. You can give an IV, but just no saline or B5W or something like that, and that would wash it out. Aspirin is very soluble, so it gets washed out pretty quickly. Long-term side effects: renal failure, high blood pressure, peptic ulcers, and increased risk of cardiovascular events, with the exception of a baby aspirin every day. When do you not give aspirin? If someone has a history of peptic ulcer disease, no aspirin, no NSAIDs. Pregnancy. FDA just came out with a new finding on pregnancy and NSAIDs. In fact, I'll even give it to you from the horse's mouth. Exposure to NSAIDs about the time of conception or during pregnancy is definitively associated with increased risk of miscarriage. The FDA has required a new warning on labels of prescription and over-the-counter NSAIDs and NSAID-containing products, and has strongly advised against their use during pregnancy beginning at 20 weeks gestation. Use of NSAIDs during this time increase a risk of fetal renal dysfunction, leading to low amniotic fluid levels, oligohydramnios, and neonatal renal impairment. NSAID labels already warned against the use of these drugs beginning at 30 weeks gestation because of the risk of premature closure of the fetal ductus arteriosus. So pregnancy NSAIDs, no.
So for all these people, like, you shouldn't give NSAIDs to, you would give them the salicylates or.
No. Acetaminophen. We're gonna say acetaminophen has a different side effect profile. Lactating mothers, NSAIDs are excreted into breast milk. And it's not good for babies' kidneys, so. Acetaminophen, it's fine, not NSAIDs. Patient has renal failure, no NSAIDs. And they inhibit platelet function, so if you have someone with some sort of bleeding disorder, the NSAIDs can make it worse, with the exception of COX-2 specific inhibitors. And COX-2 specific inhibitors have been shown to increase the risk of stroke and heart attack. All right, this is time for us to take our break. So we'll take our break, come back, talk about acetaminophen. Then we will talk about the other non-opioid analgesics. Morgan, I have your quiz. I'll give it to you, give it back to you on Wednesday.
Okay, thank you.
Yeah. It's dying. You had a good workout, Catherine?
I do.
You gonna be
Yeah, I
sore?
did some of it. Yeah.
You gonna be sore? No, you should. Those two.
Yeah, they came up later.
See, those guys are treadmill. Nurses, I get tired.
Yeah, they're crazy. No, it's good for you.
You should try to leave before you guys move. Stand all the way to the occupied.
We don't lift to match it anyways. Usually.
You go to the other gym.
Most of the baseball teams in there, and then girls, yeah, I get the range still.
Okay, that peeve about the baseball team. I've never seen more guys squat with core technique.
Oh, I know. I think it's hilarious. I love to watch it.
Guys, you kill your back.
Yep. And I just laughed.
Stop.
Ego, their ego thing.
Squatting like, God. We're going to remember the shoulders into. Look at your back.
I love to see it.
It's just.
Yeah, I think stop for 20 years back. Expected.
Yeah.
They're just like favorites.
I love when the baseball teams in that we were maxing one day. That was fun because the baseball team just sat and watched us max. Just watching it raw max. Oh. Hold on, yours. Now I don't get this time. It's like, no way. That's really what. It's like, y'all.
Salicylates are aspirin derivatives. So they're the same parent compound. Salicylic acid. Classic NSAIDs are not chemically salicylates.
Oh, okay. Okay.
Yes, maybe like
Okay, the next one I'll do is. Really speaking, I just see the genetics of golden virgin. I don't know if I can.
So I'm not still.
We have our presentation on what it's called. It's actually scary. It's actually is that your sensitive search? It was supposed to be less sensitive. Circumstances, you know, allow that. No. I don't think what's what is it? Oh, yeah. Wait, are you guys on the team? I think ours is. What? Really? We're just a fish. And I didn't realize that we were. Things like probably after 7, like, you don't I know. It's like those is like warning. I mean,
Yeah. No. Okay, I'll look at it later. Let's finish this first. Now, acetaminophen is a bird of a different feather. Here's why. Acetaminophen inhibits not COX-1, not COX-2, it inhibits COX-3. So COX-3 is only expressed in one place, and that's your brain. So COX-3 helps with pain signal transmission and processing in the brain. And by inhibiting COX-3 in the brain, it interferes with the reception of pain signals in the brain. So acetaminophen does nothing for peripheral inflammation. But it will lower fever. And it will tend to help with mild to moderate, not quite so much severe pain.
So this is probably really bad for me to admit this, but for bowling, sometimes when we have injuries, our coaches will tell us to go back and forth between Tylenol and ibuprofen. Is that like something that it's
The coach is trying to get you to not overdo the ibuprofen. And if you're like me, you don't get that much pain relief from acetaminophen. Yeah, that's me. Some people it really works well. For me, it really doesn't do very well. That's me. I know some people it works. For me, it doesn't personally work. There's an intravenous version of it now that Ofirmev. The drug companies developed it, but there's not a lot of evidence that it works that well. Any better than the tablets. Also, if you have procedures now, they'll give you preemptive amounts of, I think it's, let's see, how much? Oh, they give you like 700 milligrams preemptive acetaminophen. And I don't know why they do that because it doesn't do anything. It's only full of local, they're just fine.
But taking them like
Yeah, it's.
alternating kind of like avoids.
Right, avoids the toxicity. No, then that's your coach is onto something there. And with bowling, I mean, imagine that it's shoulders and elbows that are the big issues. No, hips, backs, knees. Okay. I don't know if any of you guys know Clarissa Balderman. She's third year. She bowled, she had to give it up because of nursing. But Clarissa used to say her foot and her knee was always hurting, essentially. Now, consequently, acetaminophen does not cause GI issues, doesn't cause kidney issues, and it does not increase the risk of stroke or heart attacks. The place, however, where acetaminophen will cause trouble is your liver. For the reasons we talked about when we discussed how acetaminophen is processed by the liver. You should not exceed 4 grams of acetaminophen a day. And since the over-the-counter tablets are 500 milligrams of acetaminophen, you should not exceed 8 tablets a day. If someone is taking a combination medication with acetaminophen, that's the number you really need to look at. And if they have a bad liver, you might need to drop that number according to their liver function.
They're still problem if they take like 8 tablets every day, won't that build up in their liver too?
Yeah, if their liver has other noise and if their liver is having to deal with other stuff, yeah. Day in and day out, it can cause a problem. So there are also acetaminophen suppositories if someone has trouble swallowing tablets. So it comes in several different types of preparations. There's a liquid suspension of it now for folks who have trouble swallowing tablets or something like that. Gosh, is there a chewable? Hold that thought. According to this, the medical letter, there isn't. But I was surprised if someone designed a chewable acetaminophen. So lots of different versions of it. There's all kinds of, yeah. So it's an analgesic, it's an antipyretic, but has no effect on platelets, no effect on inflammation. It's primarily used for mild pain, for fever, and it is first line for kids with viral infections. Some people experience GI disturbance. That's rare. It's on the order of 0.1%. or 0.5%. It's not very many people who get GI disturbance. The big issue is liver damage if you take too much of it. And keep in mind, if you go, say, up the street to Weatherwax and you pull some stuff off the shelf, you pull, Excedrin extra strength, Panadol, some of these others, you look at the labels, there's acetaminophen in them. So it's easier to OD on acetaminophen than you think it is if you're not reading labels. So if someone comes in and they say, well, I took 2 of these and 1 of those and half dozen of those, and you start looking up what's in them, before you know it, they've had 5 grams of acetaminophen. Well, how was I supposed to know? Well, you're supposed to read the label. Well, it was Panadol. Well, it wasn't Tylenol, it was the Excedrin extra strength. Well, but that can happen more easily than you think. This is the reason why many offices, if they want to know what you're on, they will say, bring your medications in a bag, a Ziploc bag, and we'll look through them. So NSAIDs, take them with food and liquids, always. Don't give aspirin to kids with viral infections. Use acetaminophen instead. And watch for GI disturbance and bleeding. GI disturbance and bleeding. And if someone is on anticoagulants, antiplatelets, NSAIDs will make their bleeding worse. Keep that in mind. Also, if a prescription NSAID doesn't work for someone, they can often switch to another one. That one might work in terms of pain relief. Allergies to NSAIDs do happen, so be aware. Someone takes the first dose and starts to get bronchoconstriction. That's a sign they might have an allergy. And then you just ask, does it work? Is the pain better? How's your pain? On that 1 to 10 scale. Pain's not improving, well, then you might want to try something else. Any questions about the NSAIDs? Very good. And we will soldier on. And let's talk about non-opioid pain relievers. So these are predominantly for neuropathic pain. So antidepressants and antiepileptics, these are predominantly the mainstay treatments for neuropathic pain. That would include diabetic neuropathy, pain associated with fibromyalgia, post-herpetic neuralgia, so-called phantom limb pain, complex regional pain syndrome, that would be things like sciatica or type of pain you get if you get a injury or you have impingement on the nerve and you get neuropathic pain in your fingers or something like that. Most of these are not FDA approved. A few are, but some are used off-label for neuropathic pain. So let's talk about the tricyclic antidepressants and the SNRIs. Selective noradrenergic reuptake inhibitors. So here are the 3 tricyclic antidepressants that are used to relieve neuropathic pain. They include amitriptyline, nortriptyline, and imipramine. Amitriptyline, nortriptyline, and imipramine. So these drugs probably work because they inhibit serotonin and norepinephrine uptake. These drugs typically are used at fairly low dosages. However, they have caveats. So they can cause orthostatic hypotension. So what do you tell your patient? They're going to have orthostatic hypotension. You tell them to get up slowly, dangle the feet first, stand up while holding things. Then when you become upright and the room stops spinning, you can proceed to walk. They may cause weight gain in some people. They can cause sedation, so they should take the drug at night. They will typically cause sexual dysfunction to some degree or another. And they will cause, because they're anticholinergics, albeit amitriptyline is the one with the lowest anticholinergic properties. So the anticholinergic effects are things like urinary retention, constipation, dry mouth, blurred vision, memory impairment, at least in older people, confusion, typically in older people. And you may not sweat as much, so you'll be hotter, usually because cholinergic neurons also innervate sweat glands. Of the SNRIs, venlafaxine is used for diabetic neuropathy, post-mastectomy pain syndrome, chemotherapy-induced neurotoxicity, and fibromyalgia, but it's not FDA approved for any of those indications. So most physicians would say venlafaxine should be used only because it's an antidepressant if someone has this pain and they also have depression. Then you should probably use venlafaxine. Duloxetine, this is a drug that goes by the trade name Cymbalta. This is FDA approved for diabetic peripheral neuropathy and myalgia. Has also been used for chronic musculoskeletal pain. When it comes to musculoskeletal pain, it's not much better than placebo. Seems to do much better with neuropathic pain than with skeletal muscular pain. Milnacipran is another SNRI that's approved, but only for use in fibromyalgia. There haven't been a lot of head-to-head studies with it and either duloxetine or venlafaxine. So is it better than those others? Hard to say. Hard to say. So the drug with the best evidence base is duloxetine when it comes to neuropathic pain. So SNRIs can cause nausea, dizziness. They can cause increased sweating. They can increase the heart rate, albeit modestly usually. They can cause constipation, urinary retention, and they cause an increase in blood pressure, but that is dose dependent. And venlafaxine is the worst for that. These others are not quite as bad. If you get off venlafaxine quickly, you can experience discontinuation syndrome. There have been reports of liver damage with these two drugs. They're not frequent reports, are pretty rare, but they have been reported. So my recommendation to you is to recommend liver function tests frequently like every 6 months or something like that, to see what their liver's doing. If you start to see evidence of liver damage, pull the drugs. When it comes to the anti-epileptics, there are a few drugs that seem to do a pretty good job with neuropathic pain. Gabapentin is definitely the one that's used the most. This is the one that goes by the trade name Neurontin. Gabapentin inhibits the voltage-gated calcium channels in the axon terminus. So that prevents the presynaptic release of neurotransmitters that mediate pain signals. Gabapentin is not processed by the liver, so it's very clean in terms of drug-drug interactions. It's essentially just excreted unchanged by the kidney. That's one of the beauties of gabapentin. But if you've got bad kidneys, it can build up. Can cause some dizziness. That's about 3% of people probably. Somnolence is actually fairly common, so you're better off taking it at night. Peripheral edema is seen in about 5% of people, and some people experience weight gain. Pregabalin, this is the one that's called Lyrica. That is similar in structure to gabapentin, works in a really similar way to gabapentin, but it's a stronger drug. And it is approved for postherpetic neuralgia and diabetic peripheral neuropathy. There's now an intramuscular pregabalin that's available. But as you can see in a randomized trial, didn't do very well. So, yeah. And it can cause some of the same side effects as pregabalin, but the pregabalin tends to cause more weight gain than gabapentin. And those two drugs are now being used as drugs of abuse. They're being diverted. So you have to take into account, is somebody drug seeking with these two drugs? What's the biggest indicator if someone is at risk for abusing? Past history of abuse. They've done it once, good chance they'll do it again. Well, better chance they'll do it again. Please, I'm not trying to be overly cynical. People can change. But my brother is a pastor. He's done a lot of marital counseling. And he gave me this one tip about marital counseling. Cheaters cheat. The guy has cheated on you once. The chance he'll cheat again is increased. Cheaters cheat. Abusers abuse. So you're going to have a bit more skepticism about someone with a previous history of abuse, right? Is that you being cynical and not believing in people? No, that's you doing your job. Remember, folks, trust is earned. Trust is earned. Just because you're taking up space and breathing air, I should trust you? And no, you earn it. Carbamazepine and some of its cousins, like oxcarbazepine, these are used for trigeminal neuralgia. Trigeminal neuralgia. Does anyone know anyone with trigeminal neuralgia? So the trigeminal nerve has the three branches. It has the ophthalmic, the maxillary, and the mandibular branches. It innervates your teeth. It innervates good parts of your orbit and things like that. People with the trigeminal neuralgia, they get this awful burning pain in their face. It's indescribable. It's like if somebody lit your face on fire, except it's not actually burning. So it turns out carbamazepine, which is an anti-seizure drug that inhibits sodium channels, is a good drug for trigeminal neuralgia. Now, carbamazepine is not terribly well tolerated. It can make you kind of spacey. Turns out its cousin, carbazepine, is better tolerated than carbamazepine. So those are two drugs for trigeminal neuralgia. They tend to be used at lower doses for trigeminal neuralgia than when they're used for seizures. The trade name of this drug, when it was not in a generic, was Tegretol, carbamazepine, Tegretol. Ziconotide is a new drug. It's an anti-seizure drug, so it is a calcium channel blocker. And this drug has been essentially not put in a pill, not put in an infusion. It's been put essentially into a little microchip that you put essentially underneath your skull, and it releases the drug at low levels, and it's quite good for neuropathic pain. People have to be willing to have a chip implanted, essentially.
This might be a dumb question. How does it get more dosage? Do they have to like go in and get more put in there?
You take the chip out and put it in there.
Looks like it.
Yeah, the surgery is actually quite minor. It can be done in your office.
How long does one last?
I'm gonna say a month, but I don't think that's right.
Insurance on that?
Insurance will cover it if everything else has failed. Three months. And the company, the drug pipeline rag I get, apparently the company is working on a chip that can last up to 6 months and even a year. Yeah. Unfortunately, there are some side effects to ziconotide. Some people have experienced things like confusion, sleepiness, unresponsiveness. Others can get paranoid reactions and psychosis. Those are not common, but they have been reported. Turns out if you start at a low dose and the chip can be programmed for that, turns out you can program it with your phone. If you start with a low dose and then titrate by very small increments, you can avoid that. And it does not cause tolerance dependence or respiratory depression, and it's not a controlled substance. So that's a upside to that. So research has shown that if you combine caffeine with certain types of painkillers like aspirin or ibuprofen, that tends to enhance its analgesic effect. Nobody knows why this works, but there have been several studies that have looked at this, and it's true. And so Excedrin, that contains caffeine with the aspirin, actually, you don't have to have quite as much aspirin or quite as much ibuprofen for it to relieve the pain. Hydroxyzine is a drug that's given typically for anxiety. And this can add to the analgesic effect of opioids, and it reduces the incidence of nausea and vomiting. So people are starting to look at adding hydroxyzine to opioids. Then there's corticosteroids. Steroids, because long-term steroid use has some pretty severe side effects. These are kind of reserved for certain conditions or for short-term dosages. They can be very useful short-term under certain conditions. Another drug that seems to improve pain in some cases is clonidine. Clonidine, of course, can cause hypotension. That's a downside of clonidine. So it can sedate you. But there's a transdermal patch of clonidine. That transdermal patch seems to give a more consistent dose of clonidine over a period of time. And that transdermal patch seems to really help with neuropathic pain in some cases. Botulinum toxin isn't just used for cosmetic purposes. It's also been looked at to treat intractable migraines and also to treat trigeminal neuralgia and diabetic neuropathy, postherpetic arthralgia, other types of intractable pain, and so on and so forth. And these treatments work. They do work. So botulinum toxin is another possibility as well. And then there are a series of topical analgesics. So you can buy lidocaine creams over the counter. These, of course, you have to keep reapplying them, but they can also cause some irritation. Lidocaine can cause some itching at the site of application. Other than that, it's pretty well tolerated. Lidocaine absorption to the skin is very minimal. Very minimal. Capsaicin is the stuff that's in hot peppers. Turns out that capsaicin cream, if applied topically, can reduce pain. It will cause usually some tingling, and it will tend to diminish sensory reception from that area. If you use capsaicin cream, you should always tell your patients to either wear some gloves or wash your hands really well afterwards. You put that on your fingers and scratch your eyes. Your eyes are going to really burn, just like if you eat the hot peppers and scratch your eyes. Ay. Yeah, you don't want to do that. So capsaicin cream, use gloves with it or use an applicator. Throw the applicator away and wash your hands afterwards. So diclofenac comes as a patch and a gel. Voltaren is available over the counter. It also comes as a solution, and it's used for musculoskeletal pain and other types of topical pain as well. Then you've got your over-the-counter stuff. There's menthol, salicylates, capsaicin, lidocaine patches that you can buy over the counter. There are 2 oral prescription cannabinoids that are available in the US. One is dronabinol, which is Marinol and is now in a generic. Marinol is very good for people who don't have an appetite. Your cancer patients often will lose their appetite. They begin to experience cachexia because the cancer is kind of taking nutrients and things from them, and they don't have an appetite. They feel lousy. They don't want to eat. So Marinol will tend to restore the appetite so the patient can eat and gain some of that weight back and feel better. Nabilone, which goes by the trade name Sesamet, is a pretty good antiemetic. So if you have nausea due to cancer chemotherapy, dronabinol is also used for anorexia in AIDS patients. They're not very good painkillers. Some people say, if your opioids aren't working, take some weed. Weed has been studied as a painkiller. It's not a good painkiller. It's not a good painkiller at all. So if weed is good for something, killing pain is not one of them. It gets you high. It's very good at that, but you'll be high and you'll still hurt. So if the patient wants to smoke weed for their pain, the problem is that they may try something else like heroin or something like that for their pain. So try to talk them down from that, I guess. Not only that, smoking weed is really bad for your lungs. You're breathing in tar, you're breathing in things from the weed. It's just bad. It's a bad idea. All right, so randomized trials of cannabinoids for pain, if they work, they don't work, they work a little bit, really not very well. And smoking cannabis doesn't really help pain. Then you've got all this non-pharmacological stuff you could do. Pilates, yoga, Tai Chi, acupuncture, massage, biofeedback, going for a walk, talking to your friend, getting a dog, you know, whatever. The American College of Physicians recommends non-pharmacological therapies first before pharmacological therapies. I think sometimes these sorts of things are really not considered first line, and they really should be first line. And if your pain can't be controlled by these other things, then maybe you should consider a medication. But I think very often we just kind of run to the pharmaceutical in our society when we don't consider there are other ways perhaps to deal with pain. Now, if your pain is severe, that's another story. You can do all the Pilates you want. You're just going to be a Pilates person who's in severe pain. But when we talk about moderate to mild pain, I think sometimes the non-pharmacological interventions get a little short shrift, and perhaps they should. So some of your athletes, and I know some of you have talked to me about injuries, you grind through the injury, you play through the injury. You're essentially trading on your body's ability to heal itself while you play. Melania, you're looking at me as if to say, well, it's a fantasy. Okay, I know soccer season, you guys play hurt. Everybody out there's playing hurt. Is that fair?
Really
Sorry?
You can't really afford that.
Nature of the game. Fast starts, stops, running into each other, people kicking you in the shin. Morons who throw their elbows and idiot refs who won't call it and stuff like that. So, you know, I see Jocelyn about ready to reach for it. Are you hurting now? Not really. Okay, it's off season. You healed. You healed, and that's usually what the athlete is trading on. Having said that, you have to know your body well enough to where it's like, hey, this is not going to get better on its own. I'm not going to be able to play with this kind of pain. Something is really wrong. If I play on this, I'm going to make it a lot worse. If I bowl with this, I'm going to make it a lot worse. If I throw with this, I'm going to have long-term issues. I really need to deal with this, so on and so forth. And that's a whole sort of thing that you're trying to deal with. All righty. Well, we've got 5 minutes left. Let me just pause right here, see if anyone has any questions. So here's what we're going to do next. So on Wednesday, we'll talk about the drugs for smoking cessation and alcohol cessation. Smoking cessation and alcohol cessation. The two different groups of drugs.
That sensation.
Stop.
Oh, okay. It was like, it's.
Sensation C.
Okay, I was like, it's not familiar to some people, but it's.
Cease would be the verb cessation. of verb.
That's fair, yeah. It's, yeah, I'm gonna eat it.
CESSATION.
Long day.
All right, Morgan, we're gonna knock off a little early today because I can't really start anything else. So there you are. So you doing
Okay,
good, Morgan?
thanks for zooming.
You doing all
Can you
right?
say that again?
Are you doing
Yeah,
okay?
I'm doing good.
All right.
Doing
Well, hang on
good,
there.
all
We'll see
right.
you Wednesday, okay?
Okay, see you
Have a
Wednesday.
good evening.